Before we get into today's episode, I want to take a moment to tell you why I've made clinician retention the focus of my work and where the show is going. I've spent years inside healthcare systems. I've seen what happens when the structure isn't set up to allow clinicians to do their best work. I've watched talented clinicians leave organizations that could have kept them. Not because the problems were insurmountable, but because no one had diagnosed them clearly enough to fix them. Here's what I know. The drivers of clinician turnover are identifiable. They're fixable, and the organizations that solve them aren't doing anything magical. They've just finally started looking in the right places. That's what this show is about. Every episode is built around the structural conditions that cause clinicians to leave, what works, what doesn't, and what executives can actually do about it. If you lead a health system, a medical group, or a clinical division, and you're tired of watching good clinicians walk out the door and go down the street to your competitors, you're exactly who I'm talking to. Now let's get to it. I'm Dr. Laura Suttin, and this is Designing Healthcare That Cares, a podcast for health system executives who are ready to stop treating turnover like a symptom and start fixing the structure behind it. Let's dive in. Welcome to the Designing Healthcare That Cares podcast. I'm really excited to have our guest today. Dr. Daniel Eiferman is a tenured professor of surgery at The Ohio State University and a Castle Connolly top doctor since 2018, a trauma and acute care surgeon known for his candid teaching style. He helps clinicians build resilience, lead teams, and navigate the emotional side of high-stakes medicine. He's most proud of his marriage to his beautiful wife, Alyssa, and his relationship with his three wonderful children, Julia, Jeffrey, and Abby. And he's got a new book out, which we'll talk about, called Cut Open, A Surgeon's Stories of Loss, Resilience, and Growth. Thanks for being here.
Hey, kid me. Thanks for having me.
Yeah, so good to talk to you. All right, so tell us, and we were talking a little bit before we hit record, you still practice.
Yep.
Recently published a book. Congrats.
Thank you.
And you talk a lot about some of the things that we don't get taught in our training, how to navigate resilience. So tell us your journey, how you found that, and what's keeping you going.
Sure. So one of my favorite stories to tell, and I actually made a little movie snippet of this that's on the website of the leadership course that I taught, is I am not kidding you. The first patient that was ever presented to me as a staff member after my 4 years of medical school, all my years of surgery training, fellowship, research, first patient residents present to me. It's like, so there's this patient who's being really non-compliant with their therapy and it's causing a lot of friction. The nurses are having difficulty with the patient. That's causing friction between the nursing staff and the residency house staff. And can you go in there and fix that? First day, first patient ever as an attending. I'm like, I know the 5 types of peptic ulcers. I know all the classifications of diverticulitis. I tell that story because I quickly learned that after all my training, which is depending if you count college or not count college, but it's over a decade to get to where I was, I didn't have a lot of the skills that I needed to be successful in what I was trained to do or was expected to do. And I realized that as physicians, we get a little bit of what's known as halo effect. Because I can operate, it must also be assumed that I can lead teams and be an effective communicator and savvy in healthcare finance. The truth is, none of that was really emphasized in my training. And that's really what started down my road of looking for topics to improve myself and then began developing courses teaching others. So that's kind of my road.
If you're watching on YouTube, you can see me nodding. It resonates with me so much. And I experienced very similar challenges when I was in a dual role. For most of my career, I was with a large health system in a dual role as practicing physician and also a senior executive. And I felt this massive imposter syndrome as a leader because I'd had leadership roles. I was chief resident. I mean, I had things here and there, but nobody really sat me down and taught me what it meant to be a leader. And I had to learn so much the hard way. I made so many mistakes and made so many people angry just because I didn't know the politics of it and I didn't know how to navigate dealing with all the personalities, but how to get things done, how to lead a team, how to have a difficult conversation with somebody who was once a peer and now somebody who reports to me. And I just couldn't agree more. It's not something that we're trained on. And so I focus heavily on clinician leaders and training clinician leaders, and then getting into now asking the questions in our teaching environment. So I'd love to hear from you. How are our teaching environments setting up these structures so that our future doctors have the leadership skills? Because just like what you said, just because somebody's a good clinician doesn't mean they're a good leader. And that's often why they're tapped on the shoulder. Like, hey, you're a great doc. You should lead our compensation committee, or you should lead our wellness committee. And it leads to imposter syndrome. So there's frustration and burnout and overextension and isolation and all the things. And it's really devastating. So I know I'm preaching to the choir, but I just resonate with that so strongly.
I'm glad it resonated.
Yeah. So tell me, I'm curious how you navigated that one situation, and then a little bit more about how that led to the book and all the teaching that you do.
So I'll be honest, that was 16 years ago. I don't totally remember all the details of what happened with that particular patient. But I guess the other side of the book to me was it starts with the worst complication of my career, which happened while I was about 6 years into practice, and things were actually going pretty well for me in my academic career. And it was tough. It was a major blow to my confidence, psyche, self-image, how I saw myself. And I had to dig in pretty deep to figure out how I was going to pick myself back up.
Yeah.
And once I finally got help getting back on that road, I started giving a talk called There's No Crying in Surgery, which is a spoof on A League of Their Own's There's No Crying in Baseball, where I don't know if you remember the scene in particular, but the outfielder, her name is Evelyn, makes a bad play. And then the inning is over and she comes in and she's met by her manager, who's Tom Hanks. Mm-hmm. And he just goes to town on her, just yelling at her. And I don't know why, but it's just like, that was me as a resident. I knew I made a mistake, and then getting berated for it did not help me perform at a higher level. And I was just like, there's a better way to do this.
Yeah.
And I dedicated a lot of time and energy, not only into physician resilience, communication styles, and navigating difficult conversations, and how to build teams and make people feel comfortable, and accepting that those who accept that mistakes are part of the process are actually more likely to go on to mastery than those who are always trying to avoid mistakes. And so I took that and then I started teaching some courses on it and got some good feedback about those. And then that's where most of those classes are the stories that you see in the book, hoping that I could get my ideas out there. Then if I could, make a small difference in some people, then I've done something good.
Yeah. Thanks for sharing that story. And the first thing that I think of is, wow, I'm really sorry to hear that happened to you. And it sounds like, if this was doing my math, it sounds like this about 10 years ago. And this culture in medicine of we don't allow ourselves to ever make a mistake, and we beat ourselves up, and other people berate us for it too. And I'm curious, how did you find your way out of that difficult time? What were the tools that you used, and how did you navigate through that?
Yeah. So this is probably my favorite topic to talk about. So there's a couple of things that I tell people. Number one, the number one things that help physicians recover after a bad outcome, complication, whatever you want to call it, is talking to somebody who does what you do. And, therefore the whole idea of peer support. Because I always tell people I've been married 16 years at the time of that complication to my beautiful wife, best friend. She's not in healthcare, not a doctor. She knew that I was sad, and she knew that I was struggling and I was distraught over a bad patient outcome. She didn't understand the nuances of what I saw in surgery and what the anatomy was and why I thought this and why I acted that way. And then one day I saw my former chairman, the person who hired me, who was my hero. He said, "How you doing, Danny?" This is in the hall. I said, "Not well." And I started to tell him the story of this patient, which is in the introduction of my book. And that's the lead story of my There's No Crying in Surgery talk. He doesn't let me finish. And he goes, "Let me tell you a story." And he goes on to tell me about a tough outcome that he had with another fantastic surgeon at our institution. And I said, "That happened to you?" Keep in mind, this guy has had every major award, every position you could have. He goes, "Yeah, Danny, it happens to everybody." I tell people that's the time that I felt like my healing began.
Yeah.
And the other thing that I talk to people about, and I wrote a little bit about it in one of the chapters in the book, is you got to have an inner circle. An inner circle are people that you trust. You trust that all they care about is your best interests.
Mm-hmm.
It's all they care about. And they love you and care about you so much that they're willing to hurt your feelings if necessary.
Yeah.
And I am very lucky to have had a mentor when I was a resident, still in touch today, who was a real strong part of my inner circle, who really helped me through this period and picked me back up and got me on my road to recovery. And then kind of my final stage is, boy, I am not the first person to have a surgical complication in the history of surgery.
Yeah.
I thought that me going out and trying to be candid and open and talk about it might help some other people bounce back quicker. And that's, again, where being a part of peer support programs, going around teaching classes, giving talks, and then, of course, the book. So that's the long answer to what was probably a relatively easy question, but that's how I bounced back.
Yeah. That sounds beautiful. And as I hear you tell it, I can definitely hear the energy coming back. And it must have felt very isolating because you talk about the importance of community. It must have felt really isolating for you at the time. And hearing about, like you said, now I realize I'm not the first one and I won't be the last. And so how can you turn this into something that could be helpful for others?
Now, one of the things that I talk a lot about is learning to talk to yourself nicely. So when that bad event happened, again, it'll be 10 years in September, my mind got pretty negative. And they talk about things called the 3 Ps, the personalization, this is my fault. But the other 2 Ps are actually a little bit more insidious and were more difficult to deal with. One, they talk about pervasiveness. So because I made a surgical mistake, I must be a bad surgeon overall. Because I'm a bad surgeon, I'm probably a bad doctor. Because I'm a bad doctor, I'm probably not a great husband. Because I'm not a great husband, I'm probably not a great dad. I'm probably not a great, and you just keep, it pervades into, I made one surgical mistake, but yet that's where your mind goes. And the last one of the 3 Ps is what's called permanence, where like, I will always be the guy that had this complication. Why would anybody ever trust me again? Why would you ever send me a patient ever again? And it wasn't until I was able to talk to some people and I learned how to talk to myself nicely, where I could say things to myself. That case did not go the way that I wanted it to. It's not what I wanted. It's not what the patient wanted. It's not what the patient's family wanted. But I'm going to learn from this. I've gained skills that a lot of people don't have. I've made a difference in a lot of different people's lives. I'm going to continue to make a difference in people's lives. I'm going to try and help the healthcare community by being open and talking about it and things like that. And that, again, was the advice that I give to people, but that was how I was able to dig out. And that's what I talk to people about. In fact, when people come to me and they struggle a little bit, usually my first question is, can you control your thoughts? Because if they can't control their thoughts, we got to be able to break that cycle, because that can be a really ugly cycle.
It's so important. And oftentimes we don't even notice how quickly we go from this there was a bad outcome or this mistake that happened to I'm a bad human. Like how quickly that spiral into that, as physicians, I don't know if we're selected for it or we become it through the process, but just this very high achieving perfectionistic tendencies, that negative voice tends to stay with us. It's so pervasive that we don't even realize it.
Our brains, for right, wrong, good, or bad, are wired that losses hurt us more than wins do. And this has been studied. So it's about, they say 2 to 2.5x of how much more losses help us than gains do. And so if that's true and you have 2 bad outcomes, or what I like to say is for every complication I have, I need 2 to 3 cases to go perfectly just to feel net even about myself.
Yeah.
Just to feel. And so, I try to do things, talk to myself. When I make a positive impact on somebody, hopefully also had a positive impact on their spouse or their kids, or maybe they're a teacher and I made a positive impact on their students, or maybe they're a coach and I made a positive impact on their team, or they're a leader in their religious community and I made a difference in their congregation. Then I'm able to spread how much good I've done to try to overcome that 2 to 2.5x bad feeling I had when the thing didn't go well. Yeah. Again, that's part of the learning to talk to yourself nicely mindset.
And that intentionality to even notice that you're having those thoughts and that they're not your own, that we're wired towards the negative, like you said, and then overcoming that with the good and celebrating the wins and the impact that you're having and really giving yourself space to feel all of that. Again, I think that's something that we as physicians, we have a really hard time noticing the good things that we are doing. We just, next patient or next case. So important.
Agreed. Other thing that I actually talk about in my No Crying in Surgery lectures, sometimes just pointing out that's the way that our brains work. And you are not an alien or have a gross personality disorder because your brain actually gives people comfort. This is normal.
Yeah.
Okay. When bad things happen, unless you have a gross personality disorder, you should feel bad.
Yeah.
And it's going to take time until you feel better. If you come to me for peer support, there is zero that I'm going to say in the moment that is going to stop the bad feelings right away. It takes time.
Yeah. We have to just sit with it sometimes. And like you said, be kind to ourselves, take care of ourselves. And the Buddhist concept of the second arrow, don't be the second arrow. Don't add insult to injury. Don't beat ourselves up on top of what else is going on.
Then you need the inner circle. You need those people who only care about you enough to go back and look at, okay, Danny, what could you have done differently? So that you don't just get to say, that happened, too bad, move on, I help other people. But you say, okay, not what I wanted. Okay, we're going to learn from this. We're going to get better. We're not going to do it in a way that makes us feel terrible about ourselves. But you do need those people in your life. They're going to be like, okay, what was your thought process of that? What were you trying to accomplish? Do you think there's a better way to do it? And then we get better.
Yeah.
It's very hard to do that in the moment. Mm-hmm. But afterwards, that's a promise that we have to make to ourselves that we go through that process.
Yeah, absolutely. I'm curious, what's been the response once you started to really bring these concepts and share your experience and your teachings with your students and with your colleagues? What was the response like?
In general, it's universally positive. But I also think that the people who have negative things to say to me just probably wouldn't come up and say them to me. But in general, my goal is always, if I give a talk to a room full of people and one person comes up to talk to me afterwards, then I usually consider that speaking engagement a success, that I reached one person and helped them on their journey. And what I try to do when I give these talks to marry the high functioning teams class that I teach with the skills that we were never taught, with the no crying in surgery, resilience type of thing, is I try to introduce that concept of vulnerability as the number one way to build trust. And when you have trust, that's the base of the pyramid that allows us to have a high functioning team.
Yeah.
And when our team functions at a high level, we are more likely to have good outcomes, to do more things, to move in the right direction. And so I try to use that talk when I come out and say, listen, this was awful for me. And it took me a long time to get over and hurt my confidence and all that stuff. My experience is that for the overwhelming majority of people, when you drop your guard first, they will turn around and drop their guard with you.
Yeah.
Then we have a connection.
Yeah.
When we have a connection and trust with each other, that's when we can give each other open and honest feedback, because I believe that it's coming from a good place.
Right.
And so if I'm able to hit home with that message and again, drop my guard first, usually the response is overwhelmingly positive.
Mm-hmm. Yeah, I can imagine. And just like any of us, right? Not everybody's going to like the message, and you just have to let them, right? Yeah.
Yeah. So this is what I say in my leadership class. I said, there are people where if you drop your guard and show your vulnerability, there's a small subset of people that will use it against you. Okay. And those people have a name. Those people are jerks. And my advice is to avoid them.
Yeah.
And remember, if you get burned, that's going to hurt you 2 to 2.5x more than it is if you make a connection with somebody. And that can be a negative spiral to get into and make you not want to show your vulnerability first. But I know no better way to gain the trust of people, especially people you haven't met before, than to do it that way. So
yeah.
In general, when you're willing to drop your guard, like I am when I give these talks, that is when I can actually make a connection with people. And I think that I make a difference.
Yeah. And that's really where the power of that inner circle too, because if we have that strong foundation and that strong inner circle, then the haters, they don't matter as much and they don't have that same power over us.
That is correct.
Yeah.
That is correct.
Are you seeing a shift in the medical training environment around how we talk about these things and how we show our emotions and connect with that?
I don't know if I'm willing to go that far yet. I don't know is the short answer on that one. I know that the amount of information to consume out there for medical students, residents, and fellows is exploding at a rate, that I don't think we ever thought was possible. And, when you talk to a curriculum designer and say, listen, I have X number of slots to fill in here. If we're going to talk about navigating difficult conversations and resilience and all that stuff, what are we taking out? Immunology,
right?
Antibiotics,
right?
Kidney function. What I have begun to see is a little bit more of yes and, where people are like, I am willing to give a little extra of my time to come to a 1-hour session at night to talk about these things, not the protected time, during the day or maybe in an official curriculum. I have been, journal clubs, book clubs, things like that. I do think it's recognized out there, but people also we're still doctors. We got to memorize the material and know what's best. In perfect world, and this is talking so far out of my comfort zone because I don't know that much about it, but there is a piece of me that wonders, is AI going to free up more of our time because of things like faster charting and auto ordering and things like that? Will that free up some of the clinicians' time to focus on other things like this? I don't know. It's in our infancy. But when people ask me, what's the future? That's what I hope for.
Yeah.
Is there a way to get some time back for what things that I call non-value added things, entering orders, stuff like that?
Yeah, absolutely. I could wax poetic about that. I'm sure you could as well.
Yeah.
Doctors doing things that don't require a physician. So that's my hope too, is that AI doesn't remove any of the humanity. It allows us to put some of the humanity back.
But when I've talked to some people, that's one of the positives that I think that it's going. I always tell people there's a couple of words that I think everybody should have their own personal definition of. And one of those words to me is the word value. People like to throw that word. I have a really simple one. Value equals outcomes over cost. So if you want your value to go up, you have two options. Your numerator, your outcomes can get better, or your denominator could go down, your cost could go down. And cost isn't always financial. It could be things like time.
Yeah.
So if I have something that will decrease the amount of time, a non-value added activity, then the overall value will go up. That's what I hope for. And I only live in the surgery world, so I don't live at like the medical school, like curriculum level. Is this stuff being taught? But I guess my answer is I hope so. I've started reading things like, I want to say it was NYU that started admitting medical students, not based on tests or GPAs, but more on their humanism and things like that. So I feel like this is out there, but I'm not in really a good place to know that much about it.
Yeah, thanks for sharing. I'm pretty disconnected from that world. So I'm always curious, folks that are in the academic environment, what are they seeing? So I share that hope with you as far as what does AI bring us?
Because in the surgery world, when you're a surgery resident, your biggest fear is that you're going to get out and not be able to do the procedures, right? I didn't get trained enough and things like that.
Right.
So you just need X number of reps, right, cases to do it and all that stuff. So you can't take that much away for them to be able to go out and be proficient. Again, it's a time issue. And my favorite chapter in my own book is chapter 2, which asks the question, what's the most important thing that you have? And my answer is your time. Time's the most important thing that you have.
Yeah, I absolutely agree. Really looking forward to reading your book.
Oh, good. Thank you.
Yeah. It's been so wonderful to talk to you.
Yeah, thank you for having me.
Sure. Yeah, it's a great conversation. We'll put links for your website and your book and your LinkedIn in the
Beautiful.
notes so folks can connect with you. I just really appreciate you being here. And thanks for everything that you're doing. It's such important work. You probably don't get a lot of thanks. So I'll say thank you on behalf of physicians. Thanks for sharing your story and bringing the vulnerability back into healthcare.
My pleasure. Thanks for having me.
If what you heard today resonates and you're ready to find out what's actually driving turnover in your organization, I'd invite you to book a retention strategy call with me. Go to drlaurasutton.com/strategy call. We'll look at what's driving clinicians out the door in your organization and what it's going to take to fix it. I'll see you next time. This podcast is for educational and informational purposes only. It is not medical advice, and it should not replace care from a qualified healthcare provider. Always seek the guidance of your physician or other qualified professional for any medical questions or decisions.